I'm Donal Macaulay. I'm the primary care editor at the BMJ, and it's my great privilege and pleasure to introduce your session this afternoon. Now, first of all, the tweets. Can I introduce our two info DJs? We have Teresa and Vijay. These guys are fantastic. They've done a wonderful job all day today, monitoring your tweets, asking the questions on your behalf. There has been fantastic activity. It has been enormous. The overall, what I was told this morning is the overall activity yesterday, at one stage there was more Twitter streaming from the Quality Forum than from Margaret Thatcher's funeral. So that's the kind of volume of tweet. So get out the phones, iPads, whatever. Do comment, reflect on what's been happening, ask questions. Now the interesting thing is, we do get questions, but don't be afraid to reflect on your own personal experience. You're going to have three very different presentations this afternoon, talking about quality from very different geographical and different scales. So don't be afraid to reflect on your experience on Twitter. We won't necessarily tell anyone who you are, but it's nice to have some kind of background on whether you think these things work or not. As a forum for questions, it's great, because there's lots of people who don't like the idea of standing up and asking a question in a big auditorium like that. So you can ask your question quietly without the sort of embarrassment of standing up. Okay, let's go. Let's take off with the session. First, Rob is going to introduce the session. Rob is the CEO of a modest-sized hospital near Amsterdam. Is that fair enough, Rob?
Yes.
Okay, well, I know many of you will have a very similar background, and I'm sure we're all very interested to hear how you're going to deconstruct and reconstruct the hospital. Rob.
Well, thank you. Ladies and gentlemen, I think that you have to overcome your postprandial dip all by yourselves. I'm not going to give you some instructions. You don't have to stand up, and you don't have to do anything else. I hope I will be able to reach you just by words and pictures. I would like to tell you something about value alignment in our hospital, because I think that is a very important concept to bring about powerful change, which in my opinion is quite necessary. And that has to do with some particular points. Hospitals, as we generally know them, are man-made, and that's obvious. And therefore they are prone to all the problems which organizations accompany when they have not been properly designed. They have come about as an historical jigsaw puzzle, and that's quite hard to manage. And they've been made on the basis of a ground plan of 19th century medical specialties. We've added about 100 additional professions and all the technical developments of the 20th century. And most of the processes of care have not been designed from the perspective of added value, but came about in a haphazard way. And they were following quite often individual professional preferences. And I think that is no theoretical problem. In the Netherlands, that results in about 1,900 preventable deaths and 30,000 cases of preventable harm. Patients stumble and fall, sometimes fatally, about the fault lines in our organizations. And that's something we have to do something about that. And I think two things can be done, essentially. To reconstruct the hospital in patient problem-oriented shops, and to align the organization around the maximization of added value for patients. And we have summarized the core business of a hospital in a value statement, and that's reflected in all the things we do. And it is not very complicated, in fact. And it's about the question whether what we do benefits our patients. It's a very basic question. It's a very professional question. And it has three elements. Is it safe, the care we provide? Does it work? Is it agreeable? And these three elements, we have them operationalized in a performance contract with our healthcare insurance, Achmea. I will come into that later. And we have we have drawn that down into all the levels of the organization. And this has to be balanced against costs, and preferably integral costs. And happily in the Netherlands we have a tremendous financial insight because of a particular payment system, and this allows for integral product definitions and integral hospital prices, including the medical specialist. And that's something unique, and that does not exist in other countries. And following the example of Virginia Mason, we included the assignment to reduce waste, and that reflects our firm belief that lean management will help us enormously in realizing our value statement. But I think that the production of high value care is strongly supported by the realization that hospitals are inherently dangerous places. Hospital care is often high risk care, and we have too often insufficient consciousness of those risks. And designing processes from the perspective of our value statement is a powerful tool to overcome that. And therefore it is clear that we must invest in the quality of the professionals. We have to invest in the quality of the administration of pharmaceuticals. We have to invest in the quality of the medical techniques we use, be it a Lancet or an MRE scan, and all that is in between. And all need their own PDCA cycle, and that is what we have developed in our hospital. And I'm quite sure, also in your organizations, that many examples exist in which our broken processes result in insufficient care and an enormous waste of resources above that. And this is a recent example of a patient who was admitted in our hospital in 2011. She was admitted 9 times in 4 months' time, and she died eventually at the end of May in the unit of cardiology. And her son issued a complaint, and our complaints official investigated the complaint and said, well, I have two minor incidents, but essentially nothing went wrong, was what she said. And of course, everything went wrong. This was an example of seriously flawed care. And well, I think that it is our task to do something about that. But the history shows another point. In hospital industry, we are still learning from the substantial number of mistakes we make, and that is the positive approach, since all too often we are not learning from them at all, or not enough. And the implication is, and that's what you can see on the right of the slide, at the bottom, that we try to hammer people through the wrong dimensioned apertures of our organizations. And that should be a major concern, and it is still happening. And I think that for us, an important development in aligning the different approaches in a hospital has been the coming about of a five-year pay-for-performance contract with our healthcare insurer, Achmea. And in this contract, several for us very important issues have been addressed. The hospital strategy, the profile, the spearheads, quality indicators, efficiency indicators, the assignment to have responsible growth. We have come to an agreement about prices, deductions, rewards, and about regional experiments. And it has been a major support in realizing the financial agreements about building a new and compact hospital, which is quite daring in this time and age in the Netherlands, I can assure you. We have summarized our strategy in a mind map, and we have added at each point, as far as possible, metrics. And of course, we tried to look ahead 10 years, which is quite a long time, and of course we will revise it. And each time we will revise it, then we will raise the bar a bit higher. And in the process of building our strategy and designing our organization, we have luckily been able to draw upon, well, the insights of many excellent scholars in the field. From Porter we have derived the concept of the integral practice unit, dedicated to a particular patient group and focused on realizing the best possible health outcomes. From Christensen we borrowed the notion that different parts of the hospital need different business models. And these parts of the hospital can be separated from each other, can be combined into a new more focused organizations, and can thereby improve their quality and value for money. And this we have abbreviated into a shop-in-shop approach. From Speer, we got the inspiration to speed up our improvement work, to involve and empower the frontline staff. We did this by introducing lean management in the whole organization. But perhaps the most powerful inspiration comes from the people of our own organization, our own people. And we're always looking for people, and Henry Ford said it beautifully, who have an infinite capacity to not know what can't be done. And I think that's a very, very gripping statement of how you should do your work. And the strength of the combination of those insights, we have combined that to clarify the network strategy of our organization, because we can't do things on our own anymore. We need other hospitals, we need different partners. Different parts of the portfolio of the hospital ask for different solutions. One size does not fit all. And the recent development in the Netherlands of mergers of hospitals into even larger and larger hospitals can be seriously be doubted because of that. We have combined our labs into larger laboratory combinations which are working as independent companies. Scheduled care such as ophthalmology or orthopedic care will be merged with specialized clinics which work on a national scale. Acute care will be combined under our own responsibility and preferably for a larger area than we are servicing now. Chronic care will be offered in networks with other hospitals, GPs, primary care providers, in order to be able to offer care in the vicinity of our patients wherever that is feasible. And if you want to do this, then you have to do this, and that you cannot read it, and that's not the meaning of the slide. But what you have to do is you have to organize your organization in business units, and business units need an integral profit and loss account. This is an integral profit and loss account of our unit of cardiology, and they can see what they do, why they earn their money, and where it is spent on. And that makes it possible to balance the costs and the income against quality. And each unit does not only need insight in profit and losses, but needs insight in quality measures. And we made the decision a couple of years ago that if we want to take this seriously, that the quality and the frequency of financial information each month should be the same for quality information. The level should be at least as high and perhaps even higher, and the frequency that goes the same for that. Since 2 years, we've been introducing an organization-wide Lean Six Sigma program. And we feel that the combination of lean insights in combination with the business strategy as outlined before offers many opportunities. And the value of lean programs, of course, has been outlined elsewhere. We are a very big fan of what's happening in Victoria Mason, for instance, and Theta Healthcare and other institutions. And also in the Netherlands, this is happening on many places. And we made this step after some previous experiences which were not so successful, because you have to learn, you have to stumble, and then you have to get up and get going. Because in 2008 our hospital was part of the Dutch Faster Better program, a nationwide improvement program, and that proved very helpful in introducing many elements of a patient safety management system. But process improvements hardly came about. These proved to be too complex and too complicated to handle from the perspective of this program. And so we hired another firm, we hired Star Plus, to try to solve it along those lines. And that approach failed partly because of insufficient education, training and buying in of the organization. And on the basis of those experiences we built a new organization-wide Lean Six Sigma program, Staying Better, and which is so far fairly successful. And yes, you always have to balance it against the costs which you are making for it and the revenues which you are finding, be it on the basis of quality or just financial. The discussion about the dark green dollars and the light green dollars. Yeah, in euros we have different colors, of course. But what happened after that, and that was quite a surprise for us, is that we could combine this in designing a new hospital. So what we have done, we've learned from the perspective of Groenen and Hagood, and we made a design brief for a completely new, very compact, lean hospital. And that framework, that is the framework for all our design decisions throughout the whole organization. And we decided to work along the lines of 5 value streams: acute care, planned care, outpatient care, clinical care, and diagnostics. And in doing this, it really came about that the whole organization was capable of joining in order to organize care from the perspective from the patient in those 5 value streams. And things happened which personally I thought would never happen, but they did. And of course, then you have to search an architect which is willing to work with you along those lines. And we found the internationally renowned firm of Meccano to do this with us. And it is the first time, at least in the Netherlands, that a new hospital is completely designed from lean principles. And I think there's quite a lot of value in it, because if you visit recently built hospitals, and it doesn't matter in which country you do that, they're too big. Those are cathedrals of care, and we have said we are not going to build a cathedral of care. We are going to build something which is really offering value for our patients. And we were able to write it down in two simple pages. And in this design brief we combined the shop-in-shop model, we combined lean design principles, and we combined principles of healing environment. And those 3 are all coming together. And this is then, well, this is what is going to happen. This is typically a picture which has been made by an architect. Well, we all love it, of course. But some important elements are there. Oversight in structure, always knowing where you are. Efficient and lean value streams, which means something for the way you design a ward, or a day clinic, or a particularly center such as our pain center. And all those elements have to be well balanced, of course, in the design. And in order to do this, you need alliances. You can't do this on your own. If you want to build an hospital which wants to take a huge step forward, then you need all the expertise you can get, and the expertise that we don't have it available. So we need partnerships to do that with us. So those are the partnerships which we developed in the last 5 years in order to bring that together and to align them along the same goals as we are striving for as an organization. And that's quite an effort. And what's relevant in this respect is that we made an agreement with the builder of our hospital in a very early stage about the maximum building costs, the maximum volume, and the operating fees for 25 years ahead. So we fairly well know what this building is going to cost us. And we deduced that from our strategy, from the business case, and thereby we defined what we will be able to pay. And that was what brought essentially the decision about to finance our project. But the building is not the essence. The essence is the care. And an interesting part which we have developed in collaboration with our partner in home care and nursing home care, Evian. You saw Evian on the slides as one of our partners, and we decided to work out a business case for a hotel-oriented facility for patients with protected revalidation after surgery, patients with recurrent pulmonary and cardiac disease, and for terminally ill patients. And in this facility, the hotel-like hospitality concept prevails. And the combined effort of all people is now taking a distinct shape, and some of the shapes you can see here. So this is what the architect designed for us. This is how it looks from the top. And there you can see the hotel in the middle, but there's also a big supermarket, health-related retail, a restaurant, outpatient departments, and the Center for Acute Care. But moreover, we found a large corridor for implementing our shop-in-shop approach. And here you see on the left one of our labels, which is Esperance. Esperance is our oncology organization, which we have developed with 3 other regional hospitals. And we have developed this as a quality formula, and a patient is seen in a multidisciplinary outpatient department. Diagnosis is quick, surgical treatment properly scheduled, chemotherapy provided in the setting of an oncology day clinic. Patients have contact with one particular nurse, and they can follow their treatment in myesperance.com. Patient satisfaction is high. Process and outcome measures are part of the performance contract with Achmea. And the same approach is used in our other specialized centers, such as our pain center or our nephrology unit. And the combined effort of all is now taking on this particular architectural shape. But it's especially it's an hospital with a close working relationship with the other healthcare providers in our region. It's a hospital with 1,500 employees. But as we say to the people who are going to work with us, you're not only an employee, you're also a member of our communication department. So we have 1,500 people working on the communications department. And we also strive for 1,500 problem solvers in the lean perspective. And we think and we feel that clear core values and alignment of the organization and its alliances according to these values create a very powerful current of change. Thank you, Mr. Chairman.
Thank you very much, Rob. What a beautiful hospital. God, it was really lovely, fantastic, beautiful.
Yes, we feel the same. Yes, we're very enthusiastic about it. Yeah, and not only, but also the patient council who is working along with us in the same lines. Yeah. They are also developing the hospital with us.
Great, super. Yeah. Now, any questions for Rob? That's great, because I'm going to ask you a question. Now, what really struck me was when you put up that slide of the patient with admissions to 5 different departments.
Yeah.
To me, as a primary care doctor, I thought, you know what? We have a hospital CEO who sees it from our perspective. Because multimorbidity is the issue for the future. It's the issue we're all grappling with. As primary care docs, we're faced with this issue. Gee, what department is this patient going to be sent to? And they go down this stream. Now, yes. I'm going to ask you the hard question. Beautiful hospital, Esperance, oh, just lovely, go to the supermarket, go to the hotel. What about the patient? Have you redesigned it for my patient with multiple morbidity?
Yes, I think we have, and we are still doing that. And that has to, you have to focus on a particular patient group. For instance, if you combine this in a pain center or a nephrology unit, then you can really focus on the problem of that particular patient. We have a very strong collaboration with our GPs, and what we are trying to do is supported by the agreement which we have with Achmea, our healthcare insurer, is to work out forms of population, the defined care, population financed care for particular patient groups. So for instance, for patients with cardiac disease and cardiac failure. So those are ways in order to combine the GPs and the hospital and the home care, nursing home care in one particular care pathway. So that's what we feel is very logically coming about in the perspective of our lean program, because that's also where you look to the added value from the perspective of your patient. And this patient, that's a hard case. So that's also a milestone to determine whether we have been doing our work properly.
Look, that is fantastic. I'd love to hear more about that. And next year, do come along with your GP colleagues and tell us how this system works, how you got this peg through the aperture, because that's a big issue for us.
That's a homework assignment, I understand. Yeah. Yes, okay, thank you.
Now, let me hand over to my GP colleague here, Vijay Luxman, who's a GP trainee, but she's also our info monitor for today. So we have some themes and some questions, Vijay.
Okay, there's been lots of Twitter feedback and lots of positive feedback about some of your concepts, especially around the idea of the value equation, and also the idea that one model won't fit all parts of the hospital and you need to have different business models for different parts of the hospital. And there's one question: how can acute care be given in a lean design?
I think that can be done very, very well. We are doing two things. We are combining the GP acute care with our hospital acute care in one acute care department, and you can design that along the levels of care patients need, from low to medium to high complexity, and you can organize along those lines. You can organize the patient pathways. So that's and our emergency department is doing this at this point in time from a lean perspective. So lean can be done in any part of the hospital. And can very well be done in acute care. Yes, I'm quite sure about that. Yes.
Okay, now we have a question. We have two questions. Vijay, okay.
Good question. How do you
if you hold on, because we'll give you a microphone. Yeah.
Okay. Sorry, my question first. Paul van den Berg from the Netherlands also. Did you design specialist wards at this time, or did you go even further, have a hotel room for a patient and all the specialist care is coming in to the patient instead of the patient going to all the other specialties?
We foresee that we have wards for acute care, for regular patient care, nursing care. And we have to work out the relationship on the level of patient pathways with the hotel facility. But in the essence, the hotel facility is not for hospital care.
The hotel room, the room in the wards.
Yes.
It's not a cardiology ward or an internal medicine ward. It's clinical care ward, and the cardiologist will come in, and the internal medicine.
It's surgical and
repeat the question
medical.
Just for the people at the back.
Okay, sorry. Yeah. Whether the differentiation between the types of ward and what we did on this point of time, we have specialized wards, but with introducing the concept of value streams along the lines of clinical care, we were able to distinguish only two lines, and that's the surgical departments and the non-surgical departments. So that's where those lines. That's where we're working on this point in time.
Oh yeah, a quick question on in your value equation you used in the denominator cost as total cost minus waste. Do you use Michael Porter's method, the book that you showed, in calculating cost, or do you use the traditional total cost? I mean, do you use the time-driven method or the capacity costing, or do you use the total? And how do you assign them across services like oncology, like the patient who was admitted 9 times? How do you assign cost?
Yeah, that's a very good question, and it probably needs a very complicated answer. And I'm a doctor by training, so I will try to help you as much as I can. You can do two things. We have organized our business units along the lines of all the types of facilities they use, and they will get charged for the use they make of them. And you can define costs on the level of the product types. We call them DBCs or DOTs, which, well, that's just the name we have assigned to them. And then you can see on the patient level what is being done to that particular patient. And so you can bundle those different categories of patients into a care pathway, and then you can optimize the care pathway from the perspective of costs. And then you can reassign that to the cost centers in your hospital. This is roundabout how roughly how it works.
Rob, I think we'll leave it at that. Thank you very much for sharing your wonderful hospital and environment. It was just a real pleasure. Thank you very much indeed.